Hello, this is Annette Rebel from the University of Kentucky. In this presentation, we'll talk about the principles of neuromonitoring. In this lecture, I will assume that you have reviewed previous podcasts on neuroanatomy and neurophysiology. So here in this podcast, we will focus on EEG or electroencephalogram monitoring, discuss genetic influences on EEG. Also will comment on the Bispectral Index, the BIS monitoring. We also will talk about brain oxygenation monitoring, either done by the jugular bulb venous saturation, direct brain tissue oxygenation monitoring, or cerebral oximetry. And we also will review evoked potential monitoring and transcranial Doppler monitoring. So let's start with the EEG, the electroencephalogram. The science and the basis behind it is that neuronal activity, the actual potential of neurons, creates an electric potential, and so therefore those neuronal activity create a field potential in the brain region. And depending on the distance from the brain region to the surface, you can capture that field potential. It can be measured. Easier if it's on the cortex than if it is a subcortical region like the thalamus. However, even though subcortical areas here are not that easy to capture, because of the high interconnection between brain regions, the field potential on the cortex does represent the field potential activity of subcortical structures. So the skull patterns do reflect both regions. So going through our what we just talked about, you look at here one neuronal spikes, a single thalamocortical neuron. If you would put in a direct electrode, would look like that. Then if it's filtered down, so here the field potential here, like you see more identifiable frequency patterns. So that's a local field oscillation. Now, since it gets filtered further throughout the neuron arch from the subcortical structure, it goes to the cortex, and then here it turns into this form of scalp EEG pattern reflecting cortical and subcortical structure field potentials. So what EEG waves and patterns do we need to be aware of? Neuronal activity and the changes of are expressed in EEG waves, and they do correlate to different physiological and non-physiological neurological statuses. The way how EEG waves are described is by frequency, so dependent on like slow, low frequency, then increasing here with your frequency pattern, like from slow, delta, theta, alpha, beta, and gamma oscillations or waves. And that's how they really look then in reality here. This is a delta wave, theta waves, alpha waves, beta pattern, gamma oscillations. In those wave patterns, they do correlate with certain activities. So for example, if I'm awake, eyes open, here I see more beta and gamma oscillations. As I'm falling asleep, here as in C, sedation, now in more prominent is alpha and beta oscillations. You see the change from this to this pattern. Now we're going to start like a more than sedation, really sleep-inducing, unconscious at surgical level. We have a more slow and alpha oscillation. As I further deepen my level of anesthesia, unconsciousness, as you would see during induction, slow oscillations. And this proceeds into more coma status, a pattern you may have heard before, burst suppression. So you have an area of almost no electrical activity, just a little bit of field potential, and then those areas where it looks like a burst. So that's why it's burst suppression. Can look like this, or when it's a higher frequency burst suppression, something more like that. And if you induce a coma, you count the amount of burst suppressions you see per window or per defined time frame. Now this is a pattern you really don't want to see too often. Isoelectric, here there's almost no field potential described. That is when an isoelectric EEG indicates there is not much brain activity, neuron activity going on at that state. So that's how EEG correlates to the functionality, to the brain neuron function. So how does how do anesthesia medication affect EEG monitoring? Propofol, it's a very lipid soluble and GABA adrenergic inhibitory, works on the GABA adrenergic inhibitory neurons, which are widely distributed throughout the cortex, thalamus, brainstem, and spinal cord. Propofol effect is present at pretty much all brain areas. So the EEG pattern you correlate with propofol is regular beta-gamma oscillations in the sedation level, and as you deepen your propofol dose, your propofol-based anesthesia, it's more slow delta oscillations down to burst suppression, and that is dose dependent. But propofol can induce burst suppression. So can etomidate, also GABA-based inhibition. It's all increased in delta oscillation as you deepen your etomidate-based sedation, as you would see during induction. Also with etomidate, you can induce burst suppression. Now ketamine, we know from the previous lecture, ketamine is different. Ketamine not only doesn't reduce cerebral blood flow, actually it increases cerebral blood flow. The mode of action, ketamine, is an MNDA inhibition, and those receptors are more represented at the limbic system than on the cortex. So as a sole agent, with ketamine, the EEG pattern you associate is the fast beta oscillations. And then as ketamine is combined with other medications, benzodiazepine, propofol, you get less regular oscillations, more in the gamma and beta pattern, but it more looks like that the EEG indicates more activity, less suppression of the cortex. Dexmedetomidine as an alpha-2 inhibitor, also working here more in the subcortical structures. Slow oscillations, delta waves, and spindles is the EEG pattern associated with dexmedetomidine. Volatile anesthetics, also we think the different mode of actions. There's a GABAergic inhibition, but also other mechanisms discussed. At 1 mAc of volatile anesthetic, the EEG pattern associated is alpha and slow delta waves. And then as you deepen your anesthetic, the theta oscillations and even volatile anesthetic can cause burst suppression at higher MAC doses. The influence of nitric oxide on EEG, relatively minor, and it really requires a high flow. It's beta-gamma oscillations down to slow delta, but not burst suppression. And also benzodiazepine, also GABA-based inhibition. Of note, benzodiazepines do not cause burst suppression, but they do cause a dose-dependent delta activity wave increase. So to summarize, EEG monitoring, it monitors neuronal activity of the brain, so therefore brain function. We are using the EEG monitoring as a surrogate for cerebral blood flow, because the brain only can function if it gets perfused. EEG is very sensitive for early detection of cerebral ischemia, and also has been used to monitor the depth of anesthesia. Depending on how many electrodes you place, between 12 to 6, 12, you have the option to get a regional analysis. However, more the cortical and subcortical structures, it's more like temporal, parietal, or frontal versus occipital, so brain region dependent. Whenever using EEG, either you have procedures with high risk for vascular injury and changes in brain perfusion, or for epilepsy, like you want to identify the focus, identify it, and then surgical resect or eliminate with laser thermal ablation. Or when you just want to map the electrocortical stimulation, what you do in a grid development. As an example, a carotid endarterectomy would be the prime example for when you want to monitor cerebral blood flow and you're using EEG as a surrogate for that. Deep circ arrest, when am I deep enough to protect the brain. Open cerebral aneurysm clipping, also here for identifying of brain ischemia, regional brain ischemia. And EEG is also used in the ICU to induce coma, either for traumatic brain injury, cerebral edema, ICP control. Now, an interoperative monitor where we're using this kind of technology quite frequently is the BIS monitor, or the Bispectral Index. We're using the same form of methodology, however it is applied with minimal technology and maximizing the information. So we are taking a very short fraction of EEG, a very localized region, but that brain pattern that I interpret as a reflection of brain activity. So the BIS is a very, very processed EEG. It has really entered our perioperative management as the monitor for brain activity to avoid the accidental awareness under general anesthesia. It is used to titrate anesthesia depth, and also, since anesthesia depth, neural activity, correlates to perfusion and circulation, it also can be used to interpret or to monitor cerebral blood flow as a substitute for better monitoring. Now, while the promise of mismonitoring has been huge, studies really have shown that BIS alone does not reliably avoid accidental awareness under general anesthesia. It helps, but it's not 100% the fixer or to avoid the situation. BIS has not been validated for all populations. Again, it's a very small portion of your frontal brain, and you use that as a surrogate for all the other brain regions. There's a lot of error source in there. The influence of our anesthetic agents on EEG and therefore BIS is not uniform. Just to mention, between propofol and volatile anesthetics, and then comparing the outliers, ketamine, nitrous oxide, and dexmedetomidine. So if you're using those medications, your BIS score not necessarily reflects your depth of anesthesia than it would be in a true only volatile anesthetic concept. And BIS does not reflect regional changes. So if you monitor the frontal brain, that may make you miss an MCA-related ischemia. Error sources with not over-interpreting BIS, not underestimating the potential, but you need to know what to do with that information. The index is influenced by your anesthetic depth and what kind of pharmacological agents you use, by pre-existing neurological diseases and already pre-anesthesia abnormal BIS levels. Muscular activity can be read as EEG and therefore being an error source. Devices like used in the operating room, your bipolar, monopolar, electrical interference, and surely also temperature has an effect on cerebral metabolic activity, so therefore also at your neuronal activity. Moving on to another brain function monitoring, the brain oxygenation monitoring. And I will discuss 3 different ways how to do that. The jugular bulb venous oxygenation saturation, the cerebral oximetry, and then also the tissue probes. The brain is a very oxygen-dependent organ. As shown in that picture, 2% of body weight uses 20% of oxygen, but that's what the brain is worth. So how do we monitor that the brain is getting enough oxygen? The jugular bulb venous oxygen saturation is kind of like the correlate of the PA catheter for the brain. But the PA catheter is for the heart. This is the PA catheter for the brain. It is an invasive technique. I don't think any of you guys have ever seen it used in the operating room or ICU. So at this point, it's probably more of historical value and explains to you what we're looking for when we monitor the brain oxygenation. And it's used in experimental settings. So as the jugular bulb venous oxygenation catheter monitors the saturation of the blood leaving the brain, okay, it reflects, if I know the saturation going in, and monitor that. So therefore I extract the oxygen extraction ratio between incoming and outgoing, so I know how much the brain has consumed. It either can be done with a fiber optic catheter versus measuring ABGs and VBGs. In the normal venous bulb, jugular bulb venous oxygenation saturation is between 60 and 70%, depending on the CMR2 or the conscious level of the patient. If that saturation is less than 50%, in studies that has been associated with poor outcome in traumatic brain injury, and if it's even lower than that, 45% and less, it's associated with worsening of your brain injury, the so-called secondary brain injury. So, as I said, like that venous saturation of outgoing cerebral blood, really more or less like a laboratory technique, not in our clinical hands. So what do we have in our clinical hands? We went so far, and it's also very invasive, we went so far that even placing probes into the brain tissue to measure the oxygen tension, so-called Lycox probe. It is a clock-type electrode, and it's placed directly into the brain. Those probes are pre-calibrated and need between 30 minutes to 2 hours to equilibrate and then to produce good numbers. You see that sometimes in the ICU, not necessarily in the operating room. And what we do in the ICU is to monitor the regional cerebral oxygenation. A normal tissue tension in the brain is around 25 to 30 millimeter mercury, assuming a normal ICP and normal cerebral perfusion pressure. Less than 10 to 15 is seen as the critical threshold for cerebral ischemia. But obviously this is very much probe dependent, probe producer dependent, and also where is the probe placed? If the probe is placed in normal brain tissue, obviously you want normal oxygenation levels. But why would you place a tissue probe in a normal level? So you want to place this tissue probe in an area at risk for cerebral ischemia, but not in the already ischemic region. So the so-called penumbra, the area at risk but is rescuable. So that is the tissue you want to fight for. So most studies recommend to place the Lycox probe in the penumbra, and then by optimizing your oxygenation level, your perfusion, and your hemoglobin, these are brain regions which then improve and are less ischemic, so therefore will improve and come out of it. The measurement is very temperature dependent, and so most of the times the sensor actually is linked to a temperature probe and then compensates those measurements based on core body temperature. When do we use those? In the ICU, obviously for brain edema management, either ischemia or traumatic brain injury, or also when you monitor for reperfusion injury, higher oxygenation level are sometimes linked to those radical oxygenation species after cerebral global cerebral ischemia. So also here Lycox probes have been used, most memorably for patients after cardiac arrest in hypothermia. So as you bring them out of the hypothermia protocol to indicate how the brain is recovering. Now the modality you most likely are going to use perioperatively for monitoring of the brain is cerebral oximetry. It is a near-infrared spectroscopy sensor. The spectrum is between 700 to 1000 nanometer wavelength. And obviously the absorption spectrum is proportional to the chromophores concentration, iron and copper. Iron for hemoglobin, copper for the cytochrome AA3. You place two sensors. The proximal records the infrared light reflected from the superficial tissue, and the distal sensor actually detects the reflection from deeper tissue, the brain. And the difference between the superficial and the deeper reflection, that is your regional cerebral oxygenation saturation. It's a non-invasive modality, as shown here in this picture, just similar to the BIS electrodes, kind of just placed on the forehead, and the absorption spectrums reflect what's underneath the bone, what is on the brain surface. Areas where we utilize this modality in CT surgery, either for cardiopulmonary bypass or for the deep hypothermic cardiac arrest to monitor your brain protection, during carotid endarterectomy, not only to monitor your cerebral blood flow, but also if there is a decrease or compromise due to one-side occlusion, what you can do if you increase your perfusion pressure, if that goes away, gets better, etc. How you optimize brain perfusion. In the ICU, also here this modality has been used for cerebral perfusion assessment as a non-invasive modality in traumatic brain injury and cerebral edema, or when you worry about cerebral hypoperfusion ischemia. The limitation of this modality, there was a lot of concerns, worried about can this technology really monitor deeper brain structures, and what's the contribution of the extracranial blood flow. Sometimes this interferes with your surgical site, so obviously this is not sterile and therefore may be in the way for the surgical approach. The monitor uses a fixed ratio between venous and arterial blood in the brain. So if you use vasodilators or pressors, that may affect the ratio between venous and arterial blood, so therefore changes your measurement. But it will not affect the trend. Okay, so the trend may still be valuable, not necessarily the absolute number as you see in this monitor, 66 or 55. But if you start out with 66 and then you go down to 40, that is probably a believable trend. But the same problem then BIS faces. This is not sensitive enough for regional changes in cerebral blood flow and cerebral perfusion. It separates left and right, but not between frontal, parietal, temporal, or occipital brain tissue. So there really is no good gold standard for clinical brain oxygenation assessment. We all still use surrogates and suboptimal monitoring options, but it's up to you to interpret the information appropriately. Let's move on to evoked potentials. Completely different monitoring modality. It focuses on that we are stimulating the loop from receptor, nerve, and then neuron, brain, CNS, and how to affect, how to monitor the chain, how those elements are functional. There are different ways how you can monitor your evoked potential depending on how you stimulate that evoked potential. Somatosensitory, motor, brainstem, and visual evoked potentials. All of this has been used in the clinical field. And as you're looking at the functionality of this nerve, spinal cord, neuron loop, you can follow this evoked potential throughout the chain, looking at amplitude and latency. Here, this is like local when you stimulate. That's when you enter the spinal cord, up the spinal cord, and up here to the cortex. Same thing for your SCP, looking at amplitude and latency. This is how I enter the spinal cord. You go through these different tracts. You're going through the medulla, and then here that is on your cortex. So on that time from start to finish, and the size, the amplitude, that's what latency and amplitude stands for. So starting with the probably most common modality used, the SSEP, the somatosensory evoked potentials. The way how it works, I stimulate a peripheral or cranial nerve, an electrical stimulus, and then you evaluate how the nerve works, how your lateral and posterior spinal column conduct that, how it arrives in the brainstem, then how it goes to the thalamic relay station, and how it's received in the sensitive cortex region. Stimulus is given. Here's the latency from when my process starts, and this is the amplitude, how strong the response was. The SSEPs are most commonly used for spine surgery. We are concerned when the amplitude changes by more than 50% or the latency prolongs more than 10%. That suggests there's neuronal damage. And based on that pattern, you can say on what level that most likely may be. Sudden changes in anesthesia depth is a major influencer of the value of EEP monitoring. So therefore, whenever you're an anesthesia provider with evoked potential monitoring, you should thrive for steady state, and anytime you have to bolus anything, you need to communicate that to the neurophysiologist monitoring your evoked potentials. When are evoked potentials affected? Abnormal baseline, if they're pre-existing blockages in this loop. Whenever amplitude latency change, you want to assess like for blood pressure, so rule out hypotension, temperature changes, and depth of anesthesia, or if position has changed, either from your stimulus, or if the patient has position has changed. If that's all negative, then the surgeon should be notified and look for surgical causes of a change in EEP loop. The motor evoked potentials, MEPs. Here's the reverse route. Okay, here we are stimulating transcranially, and then it goes through the pathway, and then we want to see a motor response. So the patient actually will be moving. We're doing that to evaluate the functionality of your motor pathway, the internal capsular, brainstem, spinal cord, and then the peripheral nerve. Also here, spine surgery, but it's a different area of your spine. As we know, we have the dorsal columns and we have the anterior, the more motor tracts. So there are two different areas, I look at during spine surgeries with SEPs and MEPs combined. The response itself takes less than 10 seconds to obtain. Same threshold of pathological than we use for the SSEPs. But since the patient will be actively moving, stimulation and vigorous contractions, they can cause tongue lacerations due to masseter contraction. So those patients need to be fitted with a bite block. And you cannot use neuromuscular blocking agents, obviously, for this modality. If they're abnormal MEPs, same thing with SACPs, like rule out ischemia, metabolic changes, mechanical trauma, or compression. You should not use this monitoring modality on patients who have epilepsy, cranial defects, cortical injuries, implanted intracranial devices, or have an increased ICP. The brainstem EPs, the auditory brainstem response, now goes to relocalized brain nerve, meaning the eighth cranial nerve. And we are stimulating the acoustic nerve, and then we monitor how this will be transmitted to the auditory system. So we're going through the auditory nerve, the cochlear nucleus, the rostral brainstem, the inferior colliculus, and then to the auditory cortex. Surgically, it's used for posterior cranial surgery, brainstem surgery, but also it can be used for coma assessment because that evoked potential is relatively robust to anesthesia influences. More than 50% amplitude reduction or latency increase for more than 1 millisecond is an indicator for risk for neuronal damage and post-op hearing loss. On the auditory brain stem response, commonly you see those different waves described. And that's exactly where you monitor your evoked potential you go through. Last not least, the visual evoked potentials. Here, a patient gets fitted with dark eyeglasses and the retina is stimulated with light flashes and responses to be then captured with electrodes on the parietal and occipital lobe, the central scalp. So here we evaluate the whole path from retina, optic nerve, optic chiasm, optic tract, then to the lateral uniculate nucleus and occipital cortex. We rarely see that used in the operating room because it's very affected by outside circumstances, neurological awareness, and obviously anesthetic drugs. But you do that as a prior assessment before you do surgeries on the visual system or to assess post-op visual abnormalities, vision loss. Summarizing this, anesthesia influences and evoked potentials. The majority of anesthetic agents have an influence on evoked potentials. The visual evoked potentials are the most vulnerable to anesthesia influences. The most rigid ones are the brain auditory evoked potential. I'm sorry, the BAAPs. The motor evoked potentials are more easily abolished than the SSEPs. At a volatile MAC, like 0.5, MEPs are almost unreadable or non-reliable for sure. Nitrous oxide alone, without modifying wave anatomy, causes only a small reduction in amplitude and latency, but most of the times it's combined with volatile anesthetics and then it potentiates the effect. The outliers here are ketamine and etomidate because these are the two agents which actually increase your evoked potential response. Ketamine increases the SSEP and MEP amplitude. If you have a pathological low baseline, you actually can use that to provoke better evoked potentials. Etomidate, most given as a bolus, increases the cortical SSEP amplitude, but no changes on subcortical or peripheral response. So maybe actually coinciding with the myoclonus. Etomidate may depress the MEP, the motor evoked potential amplitude, but not latency. Dexmedetomidine and the opiates have been seen as having no effect on evoked potentials. Other influences on evoked potentials. Obviously, hemodynamics. If function is an expression of circulation, if the SSEPs and MEPs are very sensitive to hypotension and vascular ischemia. I mean, that's why we're using it for monitoring. The evoked potentials are also affected by oxygen delivery in the arterial oxygen content, aka hematocrit. Anemia can affect the evoked potential response if cerebral oximetry delivery is not adequate for the oxygen, for the metabolic activity. We don't know what the ideal hematocrit hemoglobin level is for evoked potential monitoring, but probably it will be above 21%. Hypoxemia reduces the evoked potential response. Hypocapnia reduces the evoked potential response. Also here, as the threshold is seeing your partial pressure of carbon dioxide, the threshold is probably around 28 millimeter mercury. Temperature affects and also does glucose levels and electrolytes, most importantly magnesium and sodium. Several studies have documented the sensitivity and specificity approaching 100% when it comes to multimodal monitoring, the combination of SSEPs and MEPs for spinal cord surgery. So both those methods together probably have a very high reliability to detect new spinal cord deficits. If seeing alone, probably SSEP without MEPs, you miss the motor tract, so the sensitivity is probably then less around 50%. So that's why most of the time spine surgeries, you combine both monitoring modalities. Last not least, transcranial Doppler. This now here is not a surrogate. Now here we are getting as close as possible to cerebral blood flow as we can in the clinical arena. It's a real-time, non-invasive measurement of cerebral blood flow velocity. We're doing that in the ICU when we are worried about to evaluate and to monitor cerebral vasospasm after subarachnoid hemorrhage, or if we need a surrogate for cerebral perfusion pressure, cerebral blood flow in brain injury and cerebral edema, or for stroke management as a bedside test pre-post thrombectomy after TPA. So how does this work? So we have, yes, we have the whole scalp is bone, but there are certain windows which we can access and our Doppler probe can access through and so therefore get to the blood vessels. So here are your examination windows. Transcervical. Okay. You look at the common carotid artery and then your intracranial and extracranial carotid artery. Transtemporal. Here you are looking at MCA and ACA, first segment of the MCA and first segment of the ACA. You also can go transorbital, looking at the ophthalmic artery, and also then from posterior transforaminal, where you can assess the vertebral artery, basal artery, with luck, PCOM or PCA. Some windows are easier than others. The one for, especially in the ICU, for subarachnoid hemorrhage, vasospasm monitoring, the transtemporal, you want to look at MCA and ACA. So this transtemporal window cannot be obtained in approximately plus minus 20% of patients, but surely also the skill level of your ecotech come to play. So how's this physically done? You know, here really have your Doppler station, and here are your flow wave. And when you look at that signal, Doppler signal, you try to extract following information: your peak systolic velocity, your end diastolic velocity, and then your mean velocity. Based on this, you can calculate a pulsatility index and a resistive index. Velocity, what you measure here, is angle dependent, but as soon as you put it in the index, it is not. The mean velocity is reported as a surrogate for cerebral blood flow. So your TCD report includes all the information. So now what's normal and what we're going to do with it. So here's a printout from one of those velocity strips in what's reported: max, mean, minimal, then your PI and your RI. Your normal velocities are shown here, and within a give or take, you have certain ranges and what is normal. But obviously there's a lot of variability in patients, and also if you're on vasospasm, you may live at an abdominal level. So when is there, when do I have to treat? What really helps are those Lindegard indexes, where you look at the ratio from certain regions. So for the anterior circulation, you're going to take the mean velocity of the MCA, you divide it by the mean velocity through the extracranial internal carotid artery. For the posterior circulation, you do similar with the basal artery. You take the mean velocity of the basal artery and divide it by the mean velocity of the vertebral artery, also the extracranial portion. And here the threshold. So if the Lindegard index is above 2 for posterior circulation and above 3 for anterior circulation, that indicates you have vasospasm. But it allows you, looking at those velocity, the Lindegard index allows you to distinguish between hyperemia, stenosis, and vasospasm. So, and that's really where it helps you, based on the TCD, to come up with a good differential diagnosis. So hypoperfusion, normal pulsatility index, that's really more I worry about the cerebral infarction. Hypoperfusion, but a high pulsatility index, that's really a low circulatory state. Okay, hypocapnia, hypothermia, and a low cerebral perfusion pressure. Hyperemia, high cardiac output states, but a reperfusion injury comes to mind, as it would be after cardiac arrest, or anemia, meningitis. While this is what you most commonly see, is your vasospasm, what you see in the neuro ICU after subarachnoid hemorrhage, or ICE stenosis. Or if you have a patient who you work up for brain death diagnosis, this is the pattern you would see based on your TCD, meaning low flow state with low pulsatility index. In the folder on Canvas, you do have those reference papers, and if there's anything unclear, I really encourage you to review the resources. Thank you very much for your attention, and please feel free to contact me if you have any questions.